Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today, we are staring down the beast. And I say that with a healthy amount of, respect, but let's be honest. Pediatric cardiac nursing is the monster under the bed for a lot of students.
It really is.
Even experienced nurses transitioning to the PICU find this stuff daunting.
It is massive. It's physically intimidating because you're dealing with these tiny humans. I mean, sometimes neonates weighing less than a bag of sugar.
Right.
But then intellectually, it's just so much to juggle. You have plumbing issues, which is the actual structure of the heart. You have electrical issues. And then you have the pharmacology.
Oh, the pharmacology.
Which is a complete minefield because the safety margins in pediatrics are razor thin. What works for an adult can be a fatal dose for a neonate.
Exactly. I was just looking at the stack of sources we have for today. And it's a stack. We've got this huge, comprehensive textbook chapter on cardiovascular disorders, both congenital and acquired. And then we have these incredibly dense drug monographs for the real heavy hitters. We're talking alprostadil, indomethacin, furosemide, heparin. It's a lot of data to synthesize.
It is a lot, but our mission today is to cut right through that noise. We are not just going to read slides here. We are going to cross-reference the disease processes with that medication database to build what we call the Pareto 80-20 guide.
The Pareto principle. I love this. The idea that, 20% of the causes lead to 80% of the results.
Precisely. So the goal is to give you, the listener, the 20% of the cardiac concepts that are going to answer 80% of your exam questions.
And maybe more important.
More importantly, prevent that failure to rescue scenario at the bedside. That's the real goal.
Is moving from just memorizing lists of signs and symptoms to actually understanding the patterns.
Exactly. If you understand the flow, the basic physics of the blood, you understand the defect. If you understand the defect, the medication suddenly makes perfect sense. You don't have to memorize that indomethacin closes the duct if you understand why the duct is open and why that's a problem in that specific kid.
So we're orienting this whole deep dive for the learner today. Whether you're cramming for your finals, studying for the NCLEX, or, prepping for your very first shift in the PICU, this is designed to keep you safe and get you those keywords.
Yep. Let's do it.
Let's dive in. So before we get into the alphabet soup of defects, the ASDs, VSDs, TOFs, you've pulled together what you're calling a master 80-20 map.
I have.
These are the high-yield patterns that seem to apply across the board.
Yeah.
Can you walk us through this map? I feel like if we can get this framework right, everything else just kind of falls into place.
Right. Before you even try to memorize a single defect, you have to understand the rules of the road. And pattern number one is simply the flow problem. It's hemodynamics.
Okay.
And the golden rule here is simple physics. Blood follows the path of least resistance, always.
It's like water flowing downhill. It's just gravity, high pressure to low pressure. It's never going to decide to swim upstream unless something forces it to.
Exactly. So think about a normal, healthy heart. The left side is the high-pressure pumping system. And why is that?
It has to pump to the whole body.
The whole body. It has to push blood all the way down to your toes, up to your brain, out to your fingertips. It needs torque. It needs serious muscle. The right side, on the other hand, is a low-pressure receiving system.
It only has to get the blood next door.
Just next door to the lungs. It's a very short trip. Low resistance.
So just structurally, the left ventricle is physically thicker and stronger. Therefore, the pressure on the left is naturally going to be much higher than the pressure on the right.
Correct. So just burn that gradient into your mind. Left is high, right is low. Now, what happens if there's a hole connecting them? A septal defect, for example.
Physics takes over.
Physics takes over. Blood is going to flow from the high-pressure left side over to the low-pressure right side. We call this a left-to-right shunt.
Which means that nice oxygenated blood that was supposed to go out to the body, it's already been to the lungs, it's pink, it's ready to go, is now sneaking back into the right side.
and going back to the lungs for another lap.
To a totally unnecessary trek.
It's inefficient, it's recirculating, and that right there gives you your first major category of defects, increased pulmonary blood flow.
Okay.
These kids are pink because their blood is oxygenated. In fact, it's too oxygenated in the lungs. But their lungs are flooded, they are wet, they have pulmonary congestion, they're drowning in their own circulation.
Pink and wet. Okay, so that's side A of the map. What is the flip side?
The reverse scenario.
Yeah.
What if there is an obstruction, a blockage, a kink in the hose that prevents blood from getting to the lungs in the first place?
Like a stenotic valve.
A stenotic pulmonic valve, for example. Or if the pressure on the right side somehow becomes effectively higher than the left for some reason, blood will shunt right to left. It completely skips the lungs.
And if it skips the lungs, it never picks up oxygen, and it stays deoxygenated. It's blue blood.
Exactly. That blue, unoxygenated blood goes straight from the right side, through a defect, to the left side and out to the body. These are your decreased pulmonary blood flow defects.
And these are the blue babies.
These are the blue babies. They are cyanotic, and this is almost always a medical emergency.
Wow. Okay, so just that first distinction, pink wet lungs versus blue dry lungs, that's the first major fork in the road. That simplifies things immensely.
It's the master sorting hat for congenital defects.
What's pattern number 2 on the map?
Pattern number 2 is what I call the ductal dependent safety net. This is so critical for safety, and it's a concept that trips people up constantly on exams. We all have a ductus arteriosus as a fetus. It's a little vessel, a tunnel, that connects the pulmonary artery to the aorta. Its job is to bypass the lungs because the fetus isn't using them. It's supposed to close shortly after birth.
We'll get into that whole fetal transition in a minute, but the core concept here is that for some of these babies, that little duct is the only thing keeping them alive.
Exactly. If you have a severe obstruction, like a completely blocked valve, that duct might be the only way blood gets where it needs to go. It becomes a temporary life-saving bridge.
So the safety item, the thing you can't miss,
is knowing when we need to keep it open, using prostaglandins, and when we need to close it, using something like indomethacin. You mix those two up, you close a duct on a baby who needs it open, you kill the patient. It's that stark.
That is a sobering thought. But that's why we learn the mechanisms. It's not just memorization. Okay, pattern 3.
Pattern 3 is acquired inflammation. So now we're shifting gears. These are hearts that were built correctly. The plumbing was fine at birth. No holes, no valve issues. Everything was in the right place.
But then something attacks the heart.
Exactly. Inflammation attacks the system. Here we're talking about things like Kawasaki disease, rheumatic fever, infective endocarditis.
So for these, the exam key isn't about shunts and pressures. It's about recognizing the triggers and the unique symptoms.
Yes. It's pure pattern recognition. A history of strep throat 2 weeks ago for rheumatic fever, the classic strawberry tongue for Kawasaki. And those unique signs like Osler nodes for endocarditis, these are classic textbook symptoms that you actually see in real life, and exam writers love them.
Okay, that makes sense.
Yeah.
And finally, pattern 4 on our map.
Pattern 4 is the final destination. It's the consequence. If you don't manage the defects, if you don't manage the inflammation, you often end up at the same place. Heart failure.
But in pediatrics, heart failure looks really different than in adults, right?
So different. It's not just swollen ankles and shortness of breath. In an infant, it's growth failure. It's major feeding issues. It's that classic sign of sweating while they're eating because it's such hard work.
Okay, this map is fantastic. So, flow problem, ductal dependence, acquired inflammation, and heart failure. Let's use that to unpack the plumbing a bit more. The sources start with the fetal to newborn transition.
They do.
And I feel like you really can't understand what's wrong if you don't know how it started. This is the essential context.
Absolutely. In utero, the fetus is living in a fluid environment. The lungs are basically these little fluid-filled bags. They aren't doing any gas exchange.
The placenta is the lung.
The placenta is the lung, the kidney, the gut. It does everything. So the lungs in utero are collapsed, high-pressure, high-resistance zones. The fetal heart is brilliantly designed to bypass them entirely because sending a lot of blood there is just a waste of energy.
And it does that using 2 key shortcuts, the trapdoors.
Shortcut number 1 is the foramen ovale. This is a literal door, a flap between the right atrium and the left atrium. So blood comes back from the body into the right side, hits that door, and flows straight across to the left side, completely bypassing the right ventricle and the lungs.
Smart. And shortcut number 2
is the ductus arteriosus, which we just mentioned. This is that tunnel connecting the pulmonary artery directly to the aorta. So even the small amount of blood that does get into the pulmonary artery gets shunted through this tunnel into the aorta and then out to the body. again, bypassing the lungs.
So in a perfect world, the baby is born, takes that first big screaming breath, the lungs expand like a popped balloon.
And the pressure inside the lungs just plummets. It goes from a high-resistance system to a super low-resistance system. Blood suddenly rushes into the lungs.
And that cascade of events slams those fetal doors shut.
It does. The rush of blood returning from the newly opened lungs raises the pressure in the left atrium, which physically pushes that foramen oval door shut. At the same time, oxygen levels skyrocket in the blood, and the mother's prostaglandins are cut off, which signals the ductus arteriosus muscle to constrict and close down, usually within a day or two.
But when they don't close, or when the heart structure is so abnormal that it forces them to stay functional, that's the entire basis of congenital heart disease.
It's the whole ballgame.
Okay, let's finally get into the defects themselves.
Yeah.
We'll start with our first category from the map. The pink puffers, the increased pulmonary blood flow group. What are the main players here?
So this is your atrial septal defect, ASD, your ventricular septal defect, VSD, the patent ductus arteriosus, PDA, and a more complex one called the atrioventricular AV canal.
And the unifying theme for all of them is that left-to-right shunt we talked about, high pressure to low pressure.
Exactly. Let's take the ventricular septal defect, VSD. It's the most common congenital heart defect there is. You simply have a hole in the wall, the septum, between the ventricles.
Okay.
So when the big, strong left ventricle squeezes to pump blood out to the body, because of that hole, a jet of high-pressure oxygenated blood shoots back across into the right ventricle.
And where does the right ventricle send all its blood?
Straight to the lungs. So now the poor lungs are getting the normal amount of blood they're supposed to get from the right side. PLUS, this extra high-pressure jet of blood from the left side. The entire pulmonary vascular system gets flooded and overloaded.
So clinically, what does the nurse see at the bedside? What are the need-to-know findings for a VSD?
You see signs of heart failure, because the heart is working double time and it's inefficient. You'll see tachypnea, they're breathing fast, sometimes 60, 70, 80 breaths a minute, just trying to compensate for all that fluid.
And a fast heart rate.
Tachycardia, absolutely. But a huge one for exams and for real-life clinical practice is frequent respiratory infections.
Because wet lungs are just a perfect breeding ground for bacteria. It's a swamp.
It's a swamp, exactly. Fluid stasis leads to pneumonia and bronchitis. So if you have a baby that's coming back to the clinic over and over with recurrent pneumonia, somebody needs to put a stethoscope on their chest and listen to their heart.
And what are we getting here?
With a VSD, you're going to hear a loud, harsh, often holosystolic murmur best heard at the left sternal border. It's harsh because of that huge pressure gradient we talked about. High pressure forcing blood through a small hole makes a lot of noise.
Okay, that makes sense. Now let's talk about the Patent Ductus Arteriosus, PDA. This is that fetal tunnel that just never got the memo to close.
Right. Remember, in the fetus, this shunts blood away from the lungs, from the pulmonary artery to the aorta, but after birth, the pressures in the body flip. The aorta is now the high-pressure hose. The pulmonary artery is low pressure.
So the blood flow reverses direction through the duct.
Exactly. Now blood shunts backwards from the high-pressure aorta into the low-pressure pulmonary artery. So once again, you're flooding the lungs with extra blood.
And this has very specific murmur, right? This is a key word I see in every single review book.
It is. It's the classic exam descriptor, a continuous machinery-like murmur. It sounds like a washing machine or a humming engine because blood is flowing through it during both systole and diastole.
And another key assessment finding is wide pulse pressure. Explain that. Why does the pulse pressure widen with the PDA?
Okay, so pulse pressure is simply the difference between your systolic pressure and your diastolic pressure. In a PDA, blood is constantly leaking out of the aorta during diastole, the heart's resting phase, and flowing back into the pulmonary artery.
So the pressure in the aorta drops while the heart is resting?
It drops significantly. This causes the diastolic blood pressure to be very low. So you might see a blood pressure of, say, 100/40. That gap between 140 is huge. That's your wide pulse pressure.
Got it. Okay, now we need to integrate the pharmacology. We mentioned indomethacin at the very beginning. This is where it lives.
This is its home. This is the medical closure strategy. If we have a premature infant with a symptomatic PDA, their lungs are wet, they're in heart failure, they can't get off the ventilator, we don't want to do surgery if we can avoid it. So we give IV indomethacin or another NSAA like ibuprofen and lysine.
And these are NSAIDs. How do they work to close the duct?
So prostaglandins are the chemicals that naturally keep the duct open in the fetus. NSAIDs work by inhibiting prostaglandin synthesis. You cut off the supply of prostaglandins, and the muscle in the ductus arteriosus constricts and closes.
But we have to be really, really careful with indomethacin. I was looking at the drug monograph. This is not a benign drug for a tiny baby.
No, it has huge risks. It works by constricting blood vessels. That's great for the duct, but it doesn't just work on the duct. It can potentially constrict other vital vascular beds, specifically the kidneys and the gut.
So the need-to-know safety checks are absolutely vital here.
Absolutely. Before and during the administration of indomethacin, you are watching two organ systems like a hawk. Number one, the kidneys. Is the patient peeing? Because indomethacin can cause renal vasoconstriction, leading to oliguria, low urine output, or even acute renal failure.
You're tracking urine output hourly.
Hourly.
Mm-hmm.
And checking the creatinine before you even start. And number two, the gut. You're watching for any sign of GI bleeding, abdominal distension, or bloody stools. Because if you restrict blood flow to a preemie's already fragile gut, you can cause a devastating condition called necrotizing enterocolitis. NEC.
That is a critical safety point. So it's contraindicated in a patient with an active GI bleed, suspected NEC, or significant renal impairment. You have to check the labs, the creatinine, the platelets, before you ever hang that bag.
100%. It's a non-negotiable safety check.
Okay, that's a perfect cross-reference. Now let's move to the scarier side of the spectrum. The blue babies. Decreased pulmonary blood flow.
Yeah, these are your cyanotic defects. The core problem here is that the plumbing is blocked on the right side of the heart. The blood literally cannot get to the lungs, so it's forced to find another way out.
And that other way is to cross over to the left side, unoxygenated, and get pumped out to the body.
Exactly.
The absolute star of the show here is tetralogy of Fallot, or TOF. It feels like every test has at least one tetralogy question. It's the exam, darling.
It really is. It's the classic cyanotic defect. And it seems complex, but it actually follows a pretty clear logic. It's 4 distinct defects that occur together in one package. You have to know the 4 components.
Okay, break them down for us.
The key problem, the one that drives everything else, is number 1, pulmonic stenosis. The pulmonic valve, the door leading out of the right ventricle to the lungs, is narrowed and stiff. It's an obstruction.
A kink in the hose.
A kink in the hose. Because the right ventricle has to work so hard to push blood past this stenosis, you get defect number 2, right ventricular hypertrophy. The muscle gets thick and beefy from constantly working against high resistance.
Look, our bodybuilder.
Exactly. Then you have defect number 3, a VSD, a hole between the ventricles. And finally, defect number 4 is the overriding aorta. The aorta is kind of shifted over and sits right on top of the VSD, so it's getting blood from both the right and left ventricles.
So it's grabbing both blue blood from the right and pink blood from the left.
Correct. And the severity of the symptoms, how blue the baby is, depends almost entirely on that first one, the degree of pulmonic stenosis.
That makes sense.
If the stenosis is really tight, very little blood can get to the lungs, and the baby is profoundly cyanotic. If it's mild, they might just look a little dusky when they cry. They're called pink tets. But the classic clinical feature you absolutely need to know is the tet spell, or hypercyanotic spell.
Walk us through a tet spell. What happens? What triggers it?
It typically happens during times when oxygen demand suddenly exceeds supply. So think about it: crying, feeding, a painful procedure like an IV start, or even having a bowel movement.
Anything that stresses the baby out.
Any stressor. The infant gets upset, adrenaline surges, and this causes the smooth muscle in the right ventricular outflow tract, the area right below that already tight pulmonic valve, to spasm. It just clamps down hard.
So the door to the lungs, which was already barely open, basically slams shut.
Effectively, yes. So now almost no blood can get to the lungs. All that blue blood in the right ventricle has nowhere to go but right to left, through the VSD, and out the overriding aorta to the body.
And the baby turns
deeply blue. The oxygen saturation plummets to the 40s or 50s. They become limp, and they can even have a seizure or lose consciousness. It is terrifying to witness.
And the nursing action. This is on every single exam. The very first thing you do is what?
You put the infant in the knee-to-chest position. Or if they're an older child, they will often do this instinctively. They'll squat down on the playground.
Why does that work? It seems so simple, but the physiology behind it is actually fascinating.
It's pure, beautiful physics. By squishing their legs up against their chest, or by squatting, you kink the femoral arteries in the legs. This dramatically increases the systemic vascular resistance, SVR.
So you're increasing the pressure on the left side of the heart, in the aorta and the left ventricle.
Exactly. You are making it harder for the left ventricle to pump blood out to the body. This creates back pressure. That back pressure pushes back against the VSD.
So it makes it harder for the blue blood to shunt from right to left.
Yes. It reduces the right to left shunt and essentially forces more blood to take the only other path available through that tight, spasming pulmonary artery to the lungs. It's a mechanical manipulation of pressure.
It's absolutely brilliant. It buys you time.
It buys you critical time, but then pharmacologically, we treat those spells with morphine and, from our medication list, propranolol.
Ah, another cross-reference to our med stack.
Yeah.
Why propranolol? It's a beta blocker.
It is. It's a non-selective beta blocker. In this specific case, it has a magical effect of relaxing the smooth muscle spasm in that right ventricular outflow tract, the area called the infundibulum. It literally helps open the door to the lungs a little wider.
And the morphine.
Morphine is a central nervous system depressant. It calms the child, which is crucial because crying and agitation increase pulmonary vascular resistance and make the spell worse. It sedates them and reduces the respiratory drive slightly, which helps to break that vicious cycle of sympathetic surge and hypoxia.
So knee to chest to increase systemic resistance, propranolol to decrease the pulmonary resistance spasm, and morphine to calm the system down.
Got it. What about tricuspid atresia? That's another blue baby one.
Tricuspid atresia is basically a do not enter sign on the heart. The tricuspid valve, the door between the right atrium and the right ventricle, simply fails to develop. It's a solid sheet of tissue.
So blood can't get to the lungs the normal way at all.
Not at all. There is no path from the right atrium to the right ventricle.
So how do these babies survive even for a minute?
They absolutely require two things. One, they need a hole in ASD or a VSD to allow blood to mix and get over to the left side. And two, crucially, they require that ductus arteriosus to stay open. That's the only way blood can get to the lungs, through the back door from the aorta. This is the definition of a ductal-dependent lesion.
So if that duct closes,
The pathway to the lungs is gone, and the baby will die. Which brings us directly to the opener on our medication list, alprostadil.
alprostadil, also known by its brand name, Prostin VR, is prostaglandin E1. This drug is a lifeline. Its sole mission in this context is to maintain the patency of the ductus arteriosus. It keeps that tunnel open until a surgeon can create a more permanent solution.
But looking at the monograph for alprostadil, this is a very high-stakes medication. The side effect profile is scary.
It is. The number one absolute need-to-know clinical pearl for alprostadil is apnea.
They just stop breathing.
Yes. It happens in about 10 to 12% of neonates, and it usually happens in the first hour of starting the infusion. It has a direct suppressive effect on the respiratory center in the brainstem.
So you don't just hang the bag, set the pump, and walk away.
You never, ever walk away. You hang the bag and you stand there with the intubation kit and ambu bag ready to go. You must have ventilatory assistance immediately available. You are essentially anticipating a potential respiratory arrest.
That's a huge safety point. The monograph also mentions flushing as a side effect.
Yes, cutaneous flushing, the baby turning red, is a very common side effect due to its vasodilatory properties. But here's a really important safety nuance from the source. If you are running the infusion through an umbilical artery catheter, a UAC, and you see intense flushing just on the baby's face or upper torso, you have to be careful.
Why?
Because it might mean the catheter tip is in the wrong spot. It might be sitting too high near the vessels that go to the head and arms and shooting a concentrated dose of this potent vasodilator straight into the cerebral circulation. You have to be aware of that.
Wow. Okay. That is a fantastic clinical pearl. Let's move to the next category in the outline, the obstructive disorders. The kink in the garden hose group.
Right. So the classic one here is coarctation of the aorta. The aorta, the main artery leaving the heart, is pinched or narrowed. It's like someone stepped on the garden hose. This usually happens right after the arch, just past the point where the blood vessels branch off to the head and arms.
Okay, so if I'm visualizing the plumbing, the pinch is after the vessels that supply the head and arms, but before the vessels that go down to the legs and lower body.
Exactly. So you have a massive traffic jam upstream from the pinch and an empty low-flow highway downstream.
Which means you'd have bounding pulses and high blood pressure in the arms.
Yes. High pressure to the brain, which can risk a stroke, and high BP in the arms. And then if you check the legs, you'll find weak or even absent femoral pulses, cool skin, and low blood pressure.
Before extremity blood pressure check.
Exactly. This is the hallmark diagnostic sign. If you see a nurse taking a blood pressure on both an arm and a leg in a newborn, they are screening for coarctation. It's a standard screen in many nurseries now. If the upper extremity BP is significantly higher, like 15 to 20 points higher than the lower extremity BP, that's a huge red flag.
That makes perfect physiological sense. Now, what about the mixed defects? The source material calls these incompatible with life unless we intervene immediately. That sounds intense.
They are chaotic and complex. The big one everyone needs to know is transposition of the great arteries, TGA. It's a fundamental wiring error. The pulmonary artery and the aorta are swapped.
They're connected to the wrong ventricles.
Completely wrong. The right ventricle, which is supposed to pump blue blood to the lungs, is instead connected to the aorta. So it pumps blue deoxygenated blood back out to the bottom.
And the left ventricle?
The left ventricle, which has the nice pink oxygenated blood returning from the lungs, is connected to the pulmonary artery. So it pumps that pink blood right back to the lungs again.
It's two completely separate parallel loops that never meet. The body gets zero oxygenated blood.
Unless you have a connection. You absolutely need a VSD, an ASD, or a Patent Ductus Arteriosus to allow the blue blood and the pink blood to mix somewhere. This is another medical emergency where alprostadil is the essential bridge to surgery. You have to keep that PDA open to allow for mixing.
And the other big one mentioned is hypoplastic left heart syndrome, HLHS.
This is one of the most severe and complex defects. The entire left side of the heart, the left ventricle, the mitral valve, the aortic valve, the ascending aorta, is severely underdeveloped. It's tiny, sometimes non-existent. It simply cannot support systemic circulation.
So the treatment can't be a simple patch repair.
No, these babies are critically ill from birth. They require a series of 3 very complex staged surgical procedures, the Norwood, the Glenn, and the Fontan, that happen over the first few years of life to completely replumb the heart. Or they need a heart transplant. It's a very long and difficult road.
Okay, let's pivot now to the acquired heart diseases. So again, these aren't structural defects from birth, but inflammatory attacks on a previously normal heart. Kawasaki disease is the big one here.
Kawasaki disease is an acute systemic vasculitis. That's a fancy way of saying it's inflammation of the blood vessels, the arteries, the veins, the capillaries throughout the entire body. And for reasons we don't fully understand, it has a particular affinity for the coronary arteries.
And it's the #1 cause of acquired heart disease in kids in developed countries.
It is. That's a huge deal.
So what's the need to know for the exam? How do we spot this? The presentation seems very specific.
It is. The diagnostic criteria are very clear. First, you need a high fever, usually over 102 degrees Fahrenheit or 39 Celsius. That lasts for more than 5 days and does not respond to antibiotics or antipyretics. That's the key trigger. Then you look for the associated symptoms, and the mnemonic is Cree rash.
Okay, break down Cree rash for us.
C is for conjunctivitis. It's a non-exudative conjunctivitis, meaning red eyes without any pus or drainage, just dry, red, irritated eyes.
Okay.
R is for rash. It's usually a diffuse maculopapular rash, often on the trunk. A is for adenopathy, which means swollen lymph nodes, typically a single large one in the neck or cervical area.
And S?
S is for strawberry tongue. The tongue gets very red, swollen, and bumpy like a strawberry. You can also see very red, cracked, peeling lips. And finally, H is for hands and feet. You see swelling and redness of the palms and soles, and then later in the subacute phase, you get this characteristic peeling of the skin on the fingertips and toes.
Strawberry tongue is such a classic keyword. Now, the treatment for Kawasaki is really interesting because it breaks one of the cardinal rules of pediatrics.
It absolutely does. We give aspirin.
Ooh. We are taught from day one you never give aspirin to kids because of the risk of Ray's syndrome, which can cause devastating liver and brain damage, especially after a viral illness.
Exactly. But Kawasaki disease is the one major exception to that rule. The benefit of its potent anti-inflammatory and antiplatelet effects far outweighs the risk of Ray's. We give very high doses of aspirin initially to cool down the inflammation and then a low dose for a long time after.
And we also give IV, right? Intravenous immunoglobulin.
Yes. High-dose ID is the other cornerstone of treatment. We're essentially flooding the body with these pooled antibodies to dampen the patient's own overactive immune response. And the reason we do all this so aggressively is to prevent the crash risk.
The coronary artery aneurysms.
That's the ballgame. If you miss the diagnosis or you treat it too late after day 10 of the fever, the child has a much higher risk of developing these dangerous aneurysms or weak, bulging spots in their coronary arteries,
which can lead to blood clots, a heart attack, or long-term ischemic heart disease.
It's wild to think about. A heart attack in a toddler, it happens. And that's why the long-term monitoring with echocardiograms is so crucial for these kids, sometimes for the rest of their lives.
Okay, then we have rheumatic fever. This is the one that's connected to strep throat, right?
Yes. This is an autoimmune reaction that is a delayed sequela of a beta hemolytic streptococcus pharyngeal infection. It usually happens about 2 to 4 weeks after an untreated or partially treated case of strep throat.
So this is the kid who had a sore throat. Maybe the parent gave them antibiotics for 2 days. They felt better, so they stopped the course early.
That is the classic scenario. The antibodies the body made to fight the strep bacteria get confused, and they start to cross-react and attack the body's own tissues, specifically the joints, causing a migratory polyarthritis, the brain, causing Sydenham's chorea, which are these jerky, involuntary movements, the skin, causing a rash called erythema marginatum, and most importantly, the heart valves, causing carditis.
So the prevention is simply treating strep throat properly.
Exactly. Primary prevention is everything here. Finish your full course of antibiotics. Penicillin is still the drug of choice. And we diagnose it using something called the modified Jones criteria.
And briefly, infective endocarditis.
This is a direct bacterial or fungal infection of the inner lining of the heart, the endocardium, or the heart valves. You have to think about kids with pre-existing congenital heart defects or prosthetic valves. They are at very high risk because their blood flow is often turbulent.
And that turbulent flow can damage the lining and create a rough spot.
Exactly, a rough spot where bacteria can stick and grow, forming what's called a vegetation. But you also have to think about the entry points for the bacteria.
Like dental work.
Dental work is a major one. Bacteria from the mouth can get into the bloodstream during a cleaning or a procedure. That's why we give prophylactic antibiotics before the dentist to certain high-risk patients, like those with artificial valves or a previous history of endocarditis.
And the exam keywords for endocarditis.
The ones that always show up are ossular nodes, which are painful, red, tender nodules on the pads of the fingers and toes, and Janeway lesions, which are painless, hemorrhagic, flat spots on the palms of the hands and soles of the feet.
Okay, we've covered the defects and the inflammation. But as you said, all roads can lead to heart failure. How does heart failure look in a baby versus an adult? It's so different.
It is. In an adult, you're looking for jugular vein distension, JVD, or listening for crackles in the lungs, but you can't really see JVD in a chubby baby neck. In a baby, the signs are much subtler but very distinct. The very earliest sign is often unexplained tachycardia.
The heart is just trying to beat faster to keep up.
Exactly, to compensate for poor function. Then you'll see tachypnea, fast breathing. But the hallmark, the thing the parents will almost always tell you about, is difficulty with feeding.
The sweating with feed.
That's the one. Scalp sweating. You have to think about it. Eating is the most aerobic exercise a newborn does. It's their marathon. If they can't finish a bottle, if they get sweaty and exhausted and start breathing fast after just an ounce or two, that is activity intolerance. That is a sign of heart failure.
Which leads us perfectly into part C of our deep dive, development and milestones. How does all of this cardiac stress affect the growing child as a person?
It has a massive impact. A baby is a metabolic engine that is designed for one thing, to grow. If you are burning all of your available calories just trying to breathe and circulate blood because of a hole in your heart, you have no energy left over to put on weight. This is failure to thrive.
So clinically, we're going to see them falling off the growth chart.
Right. They'll drop from the 50th percentile for weight down to the 5th percentile. And the nursing intervention isn't just give medications. A huge part of it is nutritional management. We have to fortify the formula or breast milk
to make it more calorie dense.
Exactly. We'll increase it to 24 or 27 calories per ounce instead of the standard 20. We have to pack more punch into every single drop they can take in.
And what about energy conservation?
That's the other side of the coin. It's so important. We need to cluster our care. You don't want to be going in and waking the baby up every 15 minutes for vital signs if they desperately need to conserve energy. You do everything at once. Change the diaper, check the vitals, give them medicine, and then feed them, and then you let them rest.
What about the psychosocial impact on the family and the child?
The anxiety is real and profound. Imagine being a parent watching your child turn blue during a TED spell. It's traumatic. And for the child, there can be developmental delays. They might hit their motor milestones late because they're simply too tired to do tummy time or learn to crawl or walk.
So it's our job to monitor for that.
Absolutely. We have to monitor for those developmental red flags, but also support the family's coping mechanisms. We have to involve the child in their own care as they get older, and it's developmentally appropriate.
Okay, let's do a really deep dive now into the medication module. We've touched on a few of these already, but I want to get granular with the safety data in these monographs because the exam questions so often hinge on the side effects or the specific nursing actions.
Let's do it. So we've covered alprostadil, the opener, and indomethacin, the closer. Let's talk about furosemide Lasix.
The classic diuretic. Fluid overload management in heart failure.
Right. It's a loop diuretic. It works by inhibiting sodium and chloride reabsorption in the loop of Henle in the kidneys. Bottom line, it makes you pee out a ton of fluid. But for the exam and for the bedside, you must remember the push rule.
You have to push it slow.
Very slow. The monograph explicitly states it, 0.5 milligrams per kilogram per minute. Not just slow, it's a specific rate. If you slam Lasix the Bach push, or you give high doses too rapidly, you risk ototoxicity.
Permanent hearing loss.
Yeah.
From a diuretic.
Yes. It can be transient or it can be permanent. Can you imagine curing a child's heart failure but leaving them deaf because you were in a hurry with the IV push?
That is a can't-miss safety item, a huge one. And obviously, Lasix is famous for dumping potassium.
Oh, yeah. So you are constantly monitoring for hypokalemia, watching for muscle weakness, cramping, and most dangerously, cardiac arrhythmias. And if that kid is also on digoxin, hypokalemia dramatically increases the risk of digoxin toxicity. It's a very dangerous cycle.
Okay, now let's contrast that with lisinopril.
Lisinopril is an ACE inhibitor. It works by stopping the conversion of angiotensin the first to angiotensin the second. Angiotensin the second is a super potent vasoconstrictor, so by blocking it, the blood vessels dilate. We use it for afterload reduction. It makes it easier for the weak heart to pump against the body's resistance.
But unlike Lasix, which dumps potassium, lisinopril holds onto it.
Right. ACE inhibitors are potassium sparing, so the electrolyte imbalance you're watching for here is hyperkalemia. You have to be really careful about giving potassium supplements to a child who's on lisinopril.
And here's a massive black box warning I'm seeing in the monograph for lisinopril. Fetal toxicity.
This is huge. If you have an adolescent female patient with a cardiac condition who is on lisinopril, you must be doing pregnancy screening and education. It's known to cause oligohydramnios, low amniotic fluid, fetal skull defects, and even fetal death.
That is a critical patient education point for that specific demographic.
Yeah.
I also saw a note in the source about compounding lisinopril.
Yes, this is a practical point. Lisinopril often only comes in tablets. You can't ask a 6-month-old to swallow a pill, so the pharmacy will often have to make a liquid suspension. The source details an extemporaneous suspension crushing the tablets in simple syrup. The key for the nurse is to know that it needs to be shaken well before every dose and stored properly.
Good to know. Okay, let's talk heparin. This one terrifies me because of the potential for concentration errors.
It should. The source material highlights a long and tragic history of fatal errors with heparin in pediatrics. It comes in a catheter lock flush concentration, which is usually 10 units per ml or 100 units per ml. That's just a tiny dose to keep an IV line from clotting.
Right.
And then there's the high potency injection, which can be a 1,000, 5,000, or even 10,000 units per ml. This is used for systemic anticoagulation for treating actual blood clots.
And the vials can look very similar.
They often do. Confusing those two concentrations has killed neonates. You think you're flushing a central line with 10 units, but you accidentally give 10,000 units 1,000 times the dose and cause a massive intracranial hemorrhage.
Always, always, always double check the vial, read the label 3 times, have another nurse check it with you. And for monitoring a heparin drip?
We monitor the APT, or activated partial thromboplastin time. That's the lab value we use to titrate the drip to a therapeutic level. And another key safety point, no IM injections for any child on heparin. You will cause a massive painful hematoma.
Got it. We mentioned propranolol for TET spells, but the source says it's also used for infantile hemangiomas. That seems random.
It does, but it's very common now. A liquid formulation called hemandrol is a first-line treatment for shrinking those benign vascular birthmarks. But the key safety pearl you need to know here is the risk of hypoglycemia.
Really? A heart medication causing low blood sugar?
Yes. Beta blockers can mask the early warning signs of hypoglycemia, like jitteriness or tachycardia, because they block the body's adrenaline response. They can also inhibit glycogenolysis, which is the body's ability to break down stored sugar from the liver.
So if a baby isn't eating well and you give them propranolol,
their blood sugar can drop to dangerously low levels. So the hard and fast rule is you administer propranolol during or immediately after a feeding. You never give it if the child is vomiting or not taking their bottles well.
that is a fantastic clinical pearl. What about hydralazine?
That's a direct-acting vasodilator. It works right on the arteriolar smooth muscle to make it relax. The big side effect you have to watch for is reflex tachycardia.
The body's fighting back.
Exactly. The blood pressure drops because the vessels suddenly open up, so the heart speeds up to compensate and try to maintain cardiac output. It can defeat the purpose of the drug if you don't anticipate and manage it.
And a weird administration quirk.
The source notes that it can change color if it comes into contact with metal. That's a strange one, but good to know for drawing it up. You might need to use a filter needle or just be careful to avoid metal contact. And it also mentions a rare but serious lupus-like syndrome as a potential reaction with long-term use.
Okay, let's move into our final section, Part E synthesis. Let's connect all these dots. You mentioned the push-pull of potassium.
Yes, this is a classic exam scenario. You have a child with heart failure who is on a regimen of digoxin, furosemide, Lasix, and lisinopril. Furosemide makes you lose potassium. Lisinopril makes you retain potassium, and digoxin toxicity is massively potentiated by low potassium.
So the nurse is a tightrope walker.
You are the tightrope walker. You have to be monitoring the potassium levels constantly because tipping too far in either direction has a dangerous impact on the other drugs.
If the K+ level gets too low from the Lasix, the digoxin can become toxic, even at a normal dose.
Yeah.
If the K+ level gets too high from the lisinopril, you're at risk for fatal arrhythmias. Balance is absolutely everything.
Exactly. You have to understand how all three drugs interact.
And let's synthesize the opener versus closer one last time to really drive it home.
Let's do it.
You have a profoundly cyanotic newborn. You get an echo, and it shows TGA or tricuspid atresia. The plumbing is either crossed or completely blocked. You need mixing. You need that ductus arteriosus open.
So you give alprostadil.
You give alprostadil,
Yeah.
and you watch for apnea.
You have a premature newborn who is struggling on the ventilator. They have wet, crackly lungs, a machinery-like murmur, and bounding pulses. The duct is stuck open and it's flooding the lungs. You need it closed.
You give indomethacin.
You give indomethacin, and you watch the urine output and look for any signs of gut bleeding.
That is the 80-20 right there. If you understand that one concept, you can answer a dozen different questions correctly and safely.
Absolutely.
And let's just revisit the heart failure regimen, the classic triad of medications.
Right. It's often digoxin plus a diuretic, like Lasix, plus an ACE inhibitor, like lisinopril. Think of it in terms of what each one does for the tired pump. 1. Digoxin increases contractility. It makes the heart pump harder and more efficiently. We're improving the squeeze.
The inotropy?
Exactly. 2. Lasix removes excess fluid. It reduces preload. We're making the heart pump less volume, which reduces its workload. 3. The ACE inhibitor dilates the blood vessels. It reduces afterload. We're making it easier for the heart to pump against the resistance of the body.
Harder squeeze, less volume, less resistance. It's all about improving efficiency.
It's pure mechanics. The heart is a pump. We are just manipulating the variables to make the job easier for a tired, overworked muscle.
As we start to wrap up, I want to look at the outro thought in our outline. We've mapped the plumbing, the inflammation, the consequences, and the chemical toolkit. But what about the long term?
And that's the final provocative thought we want to leave you with. We call these surgical procedures repairs, not cures.
That's a powerful distinction.
It is. A child who has a tetralogy of fallout repair at 6 months old, what happens when they're 30? They don't just have a normal heart. They have scar tissue in their heart from the surgery. They might have a leaky pulmonary valve that will eventually need to be replaced. They are at a lifelong risk for arrhythmias because the electrical conduction tracks may have been cut during the initial surgery.
And the Kawasaki kid.
That kid who had Kawasaki at age 3. They might have permanent coronary artery scarring even if they didn't develop full-blown aneurysms. They need to monitor their cholesterol and their heart health much more aggressively as adults because they have a pre-existing condition baked into their blood vessels.
So pediatric cardiac nursing isn't just about saving the baby today. It's about setting the entire trajectory for the adult they will one day become.
That's it, exactly. You are preserving precious heart muscle for a lifetime of use. Every prompt intervention you make, every correct medication dose you give, every time you catch a subtle sign of heart failure, you are preserving function not just for tomorrow, but for decades to come.
That is a really powerful place to leave it. You've officially taken the deep dive into pediatric cardiac nursing.
Now go save some tiny hearts.